My name is Marc Humbert. I'm a pulmonologist at the South Paris University, and I'm the director of the French National Referral Center for Pulmonary Hypertension in Paris. Today, I'm going to discuss pulmonary arterial hypertension, and I will focus more strongly on the inflammatory component of this condition. And it's clear that PAH, as we say, is due to remodeling of the small pulmonary arteries, and this leads to increased pulmonary vascular resistance and right heart failure. And usually, we don't mention inflammation. However, in PAH, we know that some patients, they have comorbid conditions. The clearest one is connective tissue disease. If you have systemic lupus erythematosus or if you have scleroderma, there is an autoimmune condition. Similarly, when you are infected by HIV, you have an immune disturbance, which is quite pronounced. And also, when you have liver disease with portal hypertension, you have a lot of inflammatory reactions occurring in your body. So these conditions, they all have an inflammatory flavor. And these conditions, sometimes they can be treated with anti-inflammatory treatments, such as corticosteroids. And we know, for example, that in systemic lupus erythematosus, some patients with very severe PAH, they may improve significantly with steroids and other therapies which interfere with inflammation. So that's really a background of what is obvious in PAH. You may have PAH with a clear-cut inflammatory condition, and in some patients with this inflammatory condition, you can treat the inflammation and improve PAH. But that's, of course, a subcategory of the patients with pulmonary arterial hypertension. What is really interesting in PAH is that you have also forms of PAH which are not associated with autoimmune disease. You may have what we call idiopathic PAH or familial PAH. And what has been really interesting in our early work 20 years ago, 25 years ago, is that we identified abnormal inflammatory responses in patients with so-called idiopathic PAH, so patients with no disease whatsoever and no associated condition. So, for example, in idiopathic PAH, we found that the patients were characterized by elevated cytokines level in the bloodstream, elevated levels of interleukin-6 or interleukin-1. That's something quite clear. It was very descriptive. There was a difference between the controls and the patients with PAH. The patients with PAH, they had more inflammation as evidenced by circulating cytokines. Another very interesting thing is that when we were screening for autoimmunity, patients with no autoimmune disease whatsoever, they had autoantibodies circulating in the bloodstreams. And that was quite important because we had patients with anti-nuclear antibodies, etc. And this was what some people called form of rust of autoimmunity, so a kind of weak signal of autoimmunity. So then we did a lot of transplantation in patients with pulmonary arterial hypertension, and we had, of course, access to the lung tissue of patients with PAH. And what was quite clear is that in patients with PAH, there was inflammation surrounding the small pulmonary vessels. So the small pulmonary vessels in PAH are usually remodeled. So it means that they are thickened. The wall is multi-layer. You have too much smooth muscle cell, too many endothelial cells, and it's plugged by proliferation. But when you analyze the vessel in its totality, you find that there are some inflammatory cells, what we call T lymphocytes, B lymphocytes, macrophages, mast cells, dendritic cells. And this is important because these infiltrating inflammatory cells, they can lead to local damage. And that was quite important to identify. Another very important thing is that sometimes these inflammatory cells, they were reorganizing themselves and they were connecting with each other. And it was quite clear that in some cases, there was some kind of lymph node-like lesions around the vessel. And one could link that to the autoimmune process. You can imagine that around the vessel, there could be some immune reaction against the vessel itself. And this could lead to autoimmunity, this could lead to tissue damage, and this could lead to progression of the disease. Of course, this is in human beings, and we cannot do more than describing what is going on. And then we analyzed animal models of the disease, experimental models of the disease. And it was clear in several of these models that inflammation was not only present, but could be targeted with therapy. So it was possible in some experimental model of pulmonary hypertension, not only to see a similar inflammation around the vessel, but also treatable inflammation. So you could target it with immunosuppressants or with corticosteroids and obtain improvements in these experimental models. We have progressed a lot now, and human disease is more analyzed with better technology, especially when we do transplantation. We can analyze in great detail what was going on in the lungs. And clearly there is a network of inflammatory cells which not only accumulate, but they do act within the lesions. And it is clear that novel therapeutic options are now tested in patients with PAH in order to interfere with these inflammatory mediators. So it's not only inflammatory cells, it's also inflammatory mediators. You could say cytokine, I mentioned interleukin-6. You could say leukotrienes. You could say auto-antibodies, etc. So all these elements can be targeted with smart drugs which interfere with these pathways. So currently we have plenty of drugs to improve pH and we combine them, etc. But we need maybe a novel target and something which could be used not to replace what we have right now, but on top of what we have right now. And clearly there are some studies right now in the world, in the United States, led by Stanford University, or in the UK, led by Cambridge, or in France, led by South Paris University. And all these studies clearly have the same objective. It's not to say we are going to find right now something totally groundbreaking, but we may find something which could be an important option on top of what we have right now in order to decrease clinical worsening, to improve outcomes, to improve quality of life of our patients. And that's clearly what many people try to do right now. There are studies ongoing. There are studies with recruitment of patients, and we should hear from the results of the studies, I think, next year, mid-next year at the latest. And that's very interesting for us because we started a long time ago with descriptive studies. Then we confirmed that in experimental models, but experimental models do not tell you much then it may be important. And now we have access to interventions in patients who receive best standard of care. They are not undertreated. They receive what they should receive, but on top of that, they receive another agent which influences the inflammatory process, and that's quite important to study. My name is Marc Humbert, and I'm aware that I'm rare.